there was a new pop-up button. Okay. All right. So I would like to introduce our first speaker. His name is Robert E. Bailey II. And Robert is the Program Communications and Training Team Lead for the CDC's Division of Comprehensive Cancer Prevention and Control, or DCPC. His team is responsible for providing funding and guidance for all 50 states and the District of Columbia to advance cancer prevention, early detection and treatment, survivorship, and health equity. He has also served on multiple leadership roles in support of the CDC's COVID-19 response, including strategy, policy, partnerships, and communication lead for the Chief Health Equity Officer. The program deputy for the Community Interventions and Critical Populations Task Force, and the communications lead for the CICP Task Force. Prior to joining the Division of Cancer Prevention, Robert served as an active branch chief and team lead with CDC's Division of Community Health, where he provided oversight to the development and implementation of multi-sectoral strategies and funding to support national organizations, networks, state, community, and organizational efforts to prevent chronic illness and promote health and wellness for Americans wherever they live, work, play, worship, and learn through community transformation and health equity initiatives. Before focusing on community health, he led national partnerships, campaigns, and mobilized efforts for CDC's Division of HIV/AIDS prevention. He managed the Tuberculosis Epidemiological Studies Consortium within the divisions of tuberculosis elimination, and worked as a public health analyst on evaluation practices for Program Evaluation Research Branch. And he's also worked as a consultant for nonprofits and small businesses for infrastructures, marketing, and evaluation aspects of the organization. So hopefully technology will work. Give me just a moment here. Robert, can you, are you able to share your slides? Can you hear us? Robert, if
Hello?
Thank you, Robert. Now we can hear you. Go ahead.
Okay, can you hear me now?
Yes.
Yeah, so sorry about that. I'm having all kinds of technical issues this morning with Zoom. But thank you for your patience. Okay, hopefully you can see my title slide.
Yep, we can see you, Robert.
Oh, okay, great. Okay, so sorry about that again. Thank you so much, Star, for the introduction, and thank you all for having us this morning to talk with you for a few minutes about the role of comprehensive cancer control coalitions, to talk a bit about comprehensive cancer control. And I hope not to take up a whole lot of your time, but and I hope that you find all the information shared this morning to be helpful with all of your local comprehensive cancer control efforts. So with that, I'll go ahead and get right into it. And first, just talk a little bit about comprehensive cancer control and prevention, just to give you a bit of a background in terms of or reminders about what the division does, you know, what our priorities are, some of the programs, why coalitions are so important, and then the potential roles of coalitions in comprehensive cancer control. First of all, these are the priorities for our division. It's to ensure that all people are free of cancer with one, you know, and this is across the entire continuum, with first making sure that all cancers that can be prevented are eliminated. that we're also getting people screened at the right time and getting them connected to care as fast as possible. And also to ensure that cancer survivors live longer and healthier lives. So there are 4 foundational programs that are in the division. One is the National Breast and Cervical Cancer Early Detection Program that's been around about 30 years. We have the Colorectal Cancer Control Program, the National Comprehensive Cancer Control Program that will be celebrating 25 years actually next year in 2023, and the National Program of Cancer Registries that's celebrating 30 years this current year. And so the reason why we're here talking today has to do with the newest notice of funding announcement that was awarded a few months ago, DP 2202, that is the National Center for Chronic Disease and Prevention and Health Promotion's Cancer Prevention and Control Programs for state, territorial, and tribal organizations. So the goals of this joint notice of funding announcement are, again, to help further the division's prevention, screening, and survivor goals. One, to eliminate, again, all preventable cancers, and ensuring that the people are connected to the right screening at the right time so that we're able to get the better outcomes, that we're supporting breast and cervical cancer screening services, cancer control implementation by coalitions, and surveillance programs to monitor and report cancer burden, and that we're using a more coordinated approach to achieve all of these goals while also advancing health equity and supporting social determinants of health. So the 3 programs, this comes up periodically. This is the latest iteration of this joint NOFO. I think this is maybe the 3rd time that all 3 programs are in the same notice of funding opportunity. And the question always comes about, like, why are they all in the same program? I mean, why are all 3 programs in the same funding announcement versus each of them having their own separate funding mechanism? Well, one of the reasons is that, as you see here, all the things that you're going to be doing when it comes to comprehensive cancer control, from prevention on throughout any type of intervention, it's going to require data. It's going to require actually just doing the screening. It's going to be and it's going to be necessary to bring all these different people together in a really coordinated way to ensure that we have the right outcomes across the entire cancer continuum. And because they do have these mutual and complementary goals and strategies, that's one of the reasons why we have them all in the same notice of funding announcement. The other is that they were brought together to help with partnering to update or create the state jurisdiction-wide cancer plan. We'll talk a little bit more about that here in a few minutes. We're also expecting all 3 programs to serve as members of the Cancer Control Coalition. That wasn't necessarily always an explicit requirement for all 3 programs, that they all actually sat in the coalition, that all 3 programs actually contributed to that jurisdiction-wide cancer plan. And then the other was that the other expectation is that all the programs communicate their program contributions toward these goals and objectives by having a comprehensive logic model. So here's a glimpse of that logic model. If any of you all are bored or having any trouble sleeping at night, I probably shouldn't have said that. Feel free to read the notice of funding opportunity in its entirety. You'll find this integrated logic model at the very beginning. But you see that all 3 programs are focused on the same 5 strategies. That's to enhance the National Program of Cancer Registries data quality, completeness, use, and dissemination. They're all focused on surveillance. They're all focused on supporting partnerships in terms of delivering screening, as well as other evidence-based types of interventions, and that all are responsible for conducting program monitoring and evaluation. And then the last thing that they are all responsible for are also ensuring that every person living within the areas within the entire state or the entire island jurisdiction or the entire tribe that's funded, that they receive the utmost benefit of all the prevention, screening, and survivorship strategies that everyone is going to be implementing. And along those lines, that we are also engaging those communities, as you see highlighted here, engaging those communities that to help identify the root causes and solutions within each community. So it's not like it was an old proverb heard sometime that it was like trying to stop an epidemic or trying to stop the spread of disease, that those things are very difficult. And they likened it to trying to focusing solely on mopping the water off the floor without ever turning off the faucet. And that's essentially what it is that we're talking about when you're talking about doing going upstream and dealing with those root causes of issues. So we're intervening as well as preventing future issues. And then to that same extent, as we look at community, that we're not just solely coming in like trying to ride in on our horse like we're going to save the day, but that we're engaging community in those conversations, that they are at the table helping with the planning and helping with those interventions, and then also helping with identifying those local resources, the local resources and opportunities to actually to be able to intervene. So again, the reasons why they're all complementary. They're all focused on the same 5 strategies. We're all focused on advancing health equity. And so we need every aspect of these things in order to make the vision happen. We need the cancer and the data. The data tells us what the problem is, who's impacted, where are they? It also tells us whether or not we're making progress after we've intervened. It also tells us more about those populations, the demographics in the populations. That data also informs that overarching cancer plan. And we all recognize that cancer, like so many other diseases that we try to fight, is bigger than government to do by itself. It's bigger than any nonprofit to do by itself, any healthcare system to do by itself. It really requires everyone working together. And the thing that pulls everyone together should be that vision. The vision is going to be the thing that's going to help us ensure that we have the greatest reach, impact, and lasting change. So with that same NOFO, and so DP 2202 is that notice of funding opportunity that I mentioned before, and from here on out, I'll just probably refer to it as DP 2202 just for the sake of time, is that this is the way to kind of envision the way that all those programs work together when it comes to the plan. So for Wyoming, your overarching state plan we could use this kind of pie to show how that all works. And so with the funding that was provided for DP 2202, we haven't necessarily provided enough funding that you would be able to fund the entire plan. But what you can do though is be able to focus the efforts on the part of the pie that belongs to each one of those programs. And so DP 2202, although we fund the development of those plans and provide some implementation support, we know that the individual work plans may only take sections of that same plan. So for the National Comprehensive Cancer Control Program, which is the reason why we're all here, is that are really involved. I mean, we're really responsible for the coalitions that kind of pull everything together in terms of like that planning and implementation. The National Breast and Cervical Program, their sole focus is screening. So those aspects of the plan that have to do with breast and cervical breast and cervical screening, we would hope then or expect that program and its grantees would play a greater part in terms of leading that aspect of the plan. And then similarly with the national for the national registries, that again, what is those aspects of the plan that have to do with the data and how they inform the development of the overarching cancer plan? How is that data then used for these individual program plans for National Comprehensive Cancer Control Program or the National Breast and Cervical Program? And pleased that Wisconsin, Wisconsin, that's hilarious. I think that someone's trying to play a cruel joke on me, but for Wyoming. And I promise you, I actually have not spoken with Wisconsin. So this wasn't something that I did for Wisconsin and then trying to retrofit it for Wyoming. That's actually quite hilarious. But the fact is that each one of the states is required to have a state cancer plan. And the true belief is that individually and collectively, if we do that individually and collectively, focus on those strategies and interventions and objectives, that we will have the greatest reach and impact. So here, I'm going to pause just a minute and just talk a little bit more about the National Comprehensive Cancer Control Program, because that's the reason why you all are here. And so again, as I mentioned before, next year the National Comprehensive Cancer Control Program, or NCCCP, will be celebrating 25 years, 25 years of the program being in existence. And there are really three components to NCCCP. One, it's the importance of funding and supporting these overarching cancer control plans. So the state cancer control plans, or the tribal comprehensive cancer control plan, or an island jurisdiction cancer control plan, that all of this is done through multi-sectoral cancer coalitions, and that everybody is using evidence-based strategies to bring about policy systems and environmental improvements. So early this year, we funded 69 recipients that funded all 50 states, as well as DC, 9 tribal organizations, as well as 9 island territories and jurisdictions that were in the Pacific, as well as in the Caribbean, at about $22 to $23 million per year. Here, not expecting you all to be able to read through all this, but put this up here again just to reiterate that all the programs, including NCCCP, are all implementing those same five strategies and activities. And so we also, in addition to having the integrated logic model, every program also has its own individual logic model. And so for the rest of today's conversation, I'm really going to only focus on strategy 3 and strategy 4 of the NOPO. Strategy 3 that has to do with the partnerships for cancer control and prevention, as well as the delivery of those evidence-based interventions. But I'm going to go in reverse. They always talk about starting with the end in mind. And so one of the things that is sometimes a slippery slope when you start talking about coalitions, and there's so much focus on coalitions, or there's so much emphasis on the interventions, that you lose sight of what's the point. And the point of it all is that we're here to be able to help people, and we're hoping to help people through these 4 different areas: primary prevention, and that's the types of things like increasing access to healthy food options, increasing access to physical activity opportunities, or reducing exposure to smoke or to tobacco. It's about increasing, HPV vaccinations that will help prevent oropharyngeal cancers later in life. So every type of cancer then that we currently have the means of preventing, that we're doing everything we can to prevent those, as well as the risk, and by addressing the risk factors that support those or lead to those types of cancers, and those root causes. The other, early detection and screening. Enough can't be said. It can't be said enough, the importance of getting people screened as early as possible, because we all know that an earlier diagnosis and connection to care means oftentimes that a better quality of life, or more life after diagnoses. And then also with the cancer, with cancer survivors, that we define cancer survivors that at the moment of diagnoses, they're considered or are characterized as being a survivor. And what are all the different resources that we can provide to be able to support them, their caregivers, their family members, the healthcare providers, so again, that they're able to live the best life possible after diagnoses. And then finally, again, with health equity and social determinants of health, that we're addressing the root causes and ensuring then that everyone has the access and equal benefit of all the improvements that you all are all working on. But it's not just for the sake of, again, just having a coalition. It can't be activity for activity's sake. It's really important that we really focus our energy on those strategies that are going to affect the most people possible, with frequent exposure in a comprehensive way. So for the state of Wyoming, what we're looking for the different policy systems, environmental improvements that you're bringing about, maybe you're starting off in one city within the state, but what's going to be that that strategy over the course of the 5 years to bring that strategy, to be able to bring it to a scale that you're impacting the most people possible throughout the state. And that's through the policy systems and environmental types of improvements. And you all may have already talked about this, have already seen this particular slide and maybe or graphic in some other places, but I think it's worth revisiting where our program sits when it comes to all these different things. We talked about policy systems, environmental improvements, strategies that are going to reach the most people possible with the greatest impact. And it's not to say that smaller scale activities or more programmatic activities aren't important. They are all needed. But for the focus of DP 2202, or the funding that we're providing for National Comprehensive Cancer Control Program, this is where our focus is. So here you see at the top of the scale is where you see more of those one-on-one types of interactions, a group training. Maybe you have cooking demonstrations and those types of things. And so as you move down that pyramid, we start getting into what you are looking more like policy systems, environmental types of improvements. So if you see here, the penultimate step, we're changing the context, or I would say over the last maybe 10, 15 years, this is where a great deal of the focus has been, maybe 10 years. It's about making the individual's default decisions healthy, giving people access to healthy food options, giving access to healthy physical activity opportunities, all those things that if people are educated about the types of changes, healthy changes that they can make to help prolong their lives, then are they living in environments that make those types of things possible? It's difficult to say you need to live, eat healthy, and people don't have access to grocery stores or the stores or the stores where things are priced, where you're not spending like, $30 for organic special milk, with all the labels and bells and whistles, and it comes with glitter and all these other sorts of things that says, hey, I'm healthy. But this is where a great deal of the focus has been over these years. So in terms of, if we know that trans fats are one of those things that help, lead to some of those obesity related types of cancers, then we're getting rid of, some of those trans fats, managing the sodium intake, decreasing access to smoke, increasing access to smoke-free, tobacco-free types of environments. That has been the shift, and I would say that it's been some people have been faster than others to be able to embrace that. People love the programmatic types of things because they always make very good pictures. Everybody's going to have a bike. We're going to have a bike to work day, or we're going to have a walk. We're in October, it's Breast Cancer Awareness Month, and a lot of people we're going to have a walk, and that's great, and all those things are needed. Again, all those types of efforts are needed, but the walk is one day. So the National Comprehensive Cancer Control Program with the PSC, you're hoping maybe to create environments that helps support walking every day or on a much more frequent basis. And so with the latest NOFO, there's been a much more explicit focus on the social determinants of health, or these socioeconomic factors that are here at the very bottom of the pyramid that kind of underpin everything else that goes on. Where you're, again, you want people to live healthy. You want them to be able to buy healthy foods. You want them to be able to live in homes, where they're not necessarily exposed to smoke. You want people to be able to have health care and all those, be able to access good health care. But those things are difficult if people don't necessarily have the economic means. Some things are more difficult if you haven't necessarily had the exposure and the awareness, or if you're living in housing or different kind of conditions that are unhealthy and don't give you the opportunity, again, to practice all those types of behaviors. And so just again, another reason why, for just to kind of sum it up for the PSC, that we also emphasize these, because PSCs typically take less money, less time and effort. Once the PSC is in place, you should continue to be able to benefit from that over time with very limited time or money by your coalition or organization. So again, it's not a one-time thing. It's not episodic. it can support behavior change for larger groups of people. One of the things that we hear about are like survivor conferences, and we're going to bring survivors. Like there was one organization that said that they bring 300 survivors together every year to talk about their issues and to provide some type of support. But if you think about, states, and again, since we're talking Wyoming, we can talk about, this from a state standpoint, like how many survivors are in the state. So if you're only supporting 300, say, per year, that's nice, and that those 300 people are going to benefit from that. But what if we were able to provide that same energy toward solutions that would be able to support as many survivors as possible throughout the state? And then again, I just reiterate again that they have the built-in sustainability. Once it's in place, the change is permanent. So again, talking about keeping, the end in mind and thinking about the people, who then are we thinking about when we think of population-wide strategies? And there have been varied interpretations of this over the years, that they're like, oh, it's the people living on this block, or it's the people living within this housing community, or some people living within this particular city. And when a population-wide strategy, we're talking about trying to help everybody within the state. So health equity, we know that we hear more and more and more about health equity all the time these days. So again, just so that we're all working from a common definition for the purposes of our conversation today, is that health equity is when everyone has the opportunity to be as healthy as possible. Or the other way I like to put it, when we talk about policy systems, environmental types of improvements, that everybody is able to benefit, that everybody has the same benefit from that policy system or environmental types of or type of improvement. And that's what helps to prevent then health disparities, which then are those differences in health outcomes and causes among groups of people for any number of types of reasons. It may be historical, systemic, or it could just be the decision of where people decided to focus their time and attention. So when you all have time, this is a brand new webpage that CDC that our Division of Cancer Prevention and Control launched maybe four months ago. So as you have time, it's a good reference point to just kind of in terms of tools and resources that you may want to consider when it comes to addressing health equity in Wyoming. Because at the end of the day, we all want a healthy community, and what healthy community looks like by showing these two different schemes here, that everybody has their own idea of what a healthy community looks like. And that's totally fine, because the thing is that pulls them all together are still these same fundamental types of considerations that underpin everything that we're trying to accomplish. So as we start transitioning then to the next part of this presentation, want to just put forth these recommendations that I'm sure that you all have already tackled or maybe already considering, but it's maybe worth just restating. That it's important that as you're going throughout your work as a coalition, that you're taking time to review the data, to have the people from the registry, other organizations that have that data at the table, so that you're able to accurately prioritize cancers, geographic areas, settings, so on and so forth. And so, with the cancer plan, and the reason that you would think that is like, well, maybe it's not worth, restating, is that we see it time and time again that there has been data to prioritize, say, like, what are your top 10 cancers, or that the top 3 or 4 cancers. But then we start seeing where all the time and the effort is, it's on cancers that aren't necessarily considered the top cancer. So if breast cancer, prostate cancer, cervical cancer, skin cancer are the top 4, then why are you focused on some other more obscure types of cancer? The next thing is that you're making sure that we have different things in place, that ensuring that we're collecting the data at times, at different times, so that we're able to get a better picture of what's actually going on. Another common thing that happens is, even with this NOFO, that there is an expectation that in addition to doing the general population-wide strategies, that you're also doing tailored types of strategies for persons that may not benefit. So for example, persons living in more rural parts of the state may not benefit in the same way as people that are living closer to some of the more populated areas of the state. So, but the only way to be able to know whether or not disparities exist and to know whether or not you're actually making any progress with those disparities, then you actually have to be able to collect the type of data that's going to be able to tell you that information. The other is to make sure that the plan and that the partners that you have around the table are big enough for the problem. Before COVID came along, cancer was always referred to as the big C. Even though cancer now has been with us for a couple of years, cancer is still the big C. And so this is the reason why it needs a big plan, an aggressive plan, and people that are at the table with the time and resources and the perspectives to be able to address the kind of problems that cancer presents. And then after identifying then what are then those issues and that are driving the problem, what are then our opportunities, the biggest opportunities or challenges that may exist for the plan. Having people at the table that have taken the time to pull together a state plan or to revise a state plan is not just meant to be something that's put up on the shelf. It's meant to be something that is actually put into action. And then that you're continuing to share information with, across the coalition, as well as with decision makers, policymakers, and the general public about cancer, its effects, but also what it is that you're doing and the progress that's being made. And so the three of these things then all need to be pulled together. Those policy systems and environmental improvements, while addressing health equity and addressing the social determinants of health, because we know that the three of these give us the opportunity not only to address these things that you see here in the middle with employment, income, housing, literacy, health coverage, but ultimately we know that it may not be within the next it may not be within the 5 years of this program, but we do know that these things, if we're able to address these things, will positively impact mortality rates, morbidity rates, be able to improve life expectancy. And then I would say even more so than just in addition to the life expectancy, the quality of life that people are going to live. So I use this example, Georgia, often as we start talking about bringing things to scale and helping the most people possible, having the partners at the table that are going to be able to help you do this. Because again, we are not interested in just doing, things that are just going to impact, one block within the state or just one particular community. What are the types of organizations in that we can work with that can help us with that statewide reach, and are they at the table? So for this example, let's say like the health department here based in Atlanta, it wants to be able to impact employers across the state or those that have anything to do with that have workers for them. Now, you could, if you had, I don't know, maybe 50, 60, 70 years, the health department could go around to each one of those, or the coalition could go around to each one of those and try to recruit each one of them to be to put this policy system environmental type of approach in place. Or you could start looking at who are those statewide partners, who are the people that actually have the type of time and, not the time, well, the resources to be able to, and the influence to be able to reach many more organizations over time. And this is just a workplace example or a business example, but it could apply to schools. It could apply to to faith organizations. So here in this example, if you partner with the State Chamber of Commerce, then the State Chamber of Commerce, then if they're at the table and a part of the coalition, can then help to lead the efforts then to expand or to distribute or to recommend that policy system environmental improvement for the various members. And so, of course, if you do that for Georgia, what we're talking about is Wyoming and Star, and again, I would like to thank her for her leadership and for bringing us on here today. Noah's well aware as that has been a part of meetings where we've talked about this types of things, and has also been quite vocal about the type of issues that are unique to working in Wyoming. This isn't a place where you're going to have like pockets of millions of people But the same types of things, those same type of strategies, again, in a cultural, in the proper cultural context, in cultural context, meaning what's culturally appropriate for Wyoming, it still is possible. And these four different aspects of the work, or three different aspects, are still going to be important: the data, the coalition, the service delivery, and again, the data at the end to make sure that we're tracking progress. So bringing them all together is what the issue is. So here in the middle is the vision, again, that we talked about, the vision and the plan. And so it requires having all these different types of sectors at the table to be able to make things happen. So in terms of your own partnership coalition and the considerations, there were a couple of things just wanted everyone to kind of be aware of for this particular NOFO. One, with the changes with this newest NOFO, one has been that the program director and program manager, as I've said before, the program, cancer is too big for any program to do this alone. And so the health department, our focus in this time was then to make sure then that program director and the program manager were 100% focused on NCCCP or this particular program, and in that respect, that they were able to do what they use that time to be able to educate coalition members, to be able to make resources available to coalition members to help them to help them with identifying the problem, like what are the priorities, help them with identifying, working with groups to help identify new members, as well as coordinating with the leadership of the other programs. Just as mentioned before, again, all three programs are in this NOFO, the breast and cervical program, as you see here, NB, CCEDP, and the National Registry program. And so doing that coordination with those leaderships so they would make sure those goals and objectives continue to be complementary. The other is that there needs to be a great focus on coalition composition and member roles for the work plan as well as the cancer plan. You have the overarching cancer plan, but as I mentioned before, the DP 2202 through the National Comprehensive Cancer Control Program, what then are you doing as a part of your overarching cancer plan, but what's also like some of the more focused work that you're doing for the DP 2202 work plan. And this can be accomplished through formal and informal coalitions. We know that it's great when you're able to have formal coalitions, but it's also the consideration that, everyone that can help support the coalition doesn't always necessarily have to be a member. Membership does and should have its privileges, but for there may be some folks that come in and may be more episodic in terms of like what the roles are with the coalition. The other is in terms of having the business case. What is the benefit of being associated with the coalition and being associated with this work, and how do we make that case for multi-sectoral leaders that can help you have the jurisdiction-wide type of reach and impact that you want to have? And then again, how are we then going about monitoring and reporting that success? So bringing your friends to the table. If I was to pause and ask everyone to raise your hand if and tell us what your end of agenda is, or questions about whether or not everyone that's at the table has a different agenda. The answer is everybody has an agenda that's at the table. The thing that's important is that despite what your reasons for being at the table, if we all are able to keep the vision in mind of what we're trying to accomplish together, that should be the thing that helps us sustain the coalition, that helps us sustain the work, and helps to ensure that we have the collective impact that we need. We all don't necessarily have to, my organization, the reason why we're here may be completely different from some going to be doing work that's going to help to prevent cancer, get people screened, and help to support survivors. So all in terms of the roles, I won't revisit this again, but again, all those programs have specific roles to play in the coalition. I already talked about, as a reminder, NCCCP doing the convening, National Breast and Cervical focused on breast and cervical cancer screening, the registry providing the data. And the other thing that happens, in addition to we start talking about this overarching cancer plan, that there's also a role in helping to educate, using this information to be able to educate policymakers, influential leaders, the public about the impact that cancer is having in Wyoming and what are the opportunities to be able to address it. So, you would think then that, and this is one of the other things that see commonly, that you have some coalitions where everyone that's a member of the coalition has some type of health affiliation, or public, health or public health type of affiliation, when the fact is that cancer impacts every single sector, wherever they live, work, play, worship, learn. It's arts and entertainment, it's business and labor, civic, social, education, faith, health, the media, foundations, policymakers. I mean, it impacts it all. There's a business case for every single group being a part of this effort. And the most recent examples you would have had of this outside of your own cancer coalition would be COVID. It didn't matter what people were doing. If you were making widgets or you were running an amusement park, from Mickey Mouse to, CEOs to faith leaders, everyone had a different message or different role that they could have, because their membership, if they're parishioners, the amusement park attendees, healthcare workers, everybody was impacted in some way or another, directly or indirectly, by COVID. And that's the same thing for cancer. Everyone we need a more comprehensive approach then it brings all these sectors together. And so this is a different way to maybe to envision what the public health system looks like. It's not just about the health department doing work, or maybe a CDC or some other type of federal agency being responsible. And I know that in Wyoming, that's probably not popular. From the people that I've known, are, Wyoming fiercely independent, with not wanting to have, much in the way of any type of government intervention. So believe me, I totally, totally appreciate that. But that also means that there's even a greater reason then for making sure that all these other sectors are at the table to helping with the planning and the implementation of your plan. So just like with most families, and a coalition is a family, they say sometimes you're able to choose your family, sometimes you're not, that everything may not have always been great over the past. And I don't know a great deal about, why anything that may have been, issues that Wyoming has had in the past, but just speaking solely of from experience with other types of coalitions, small as well as large, that there typically has always been at some point some type of friction for one reason or another. Maybe their personal differences that people actually brought to the coalition. I know that people that have not joined coalitions because they found out that another organization was a part of it. I know that some people have been less prone to be able to share like what their plans are, that could help maybe with some of those types of collective efforts and planning, and be able to maximize results because of fear of people taking that information and doing something else with it. But let's put that all aside. Hey, let's all make up. Now, again, not knowing anything about your own, and even if it wasn't, that there's always a time to be able to begin again, which is the reason why I love this African proverb, that the best time to plant a tree was 20 years ago. The second best time is now. So it doesn't matter what was the water under the bridge, what has been the history. If there is a collective will to be able to focus on something that's bigger than our individual relationships, or the individual problems that we may have, and in this case, cancer, then we know that when comprehensive cancer control coalitions come together to do work, that we can prevent cancer, that we can get people screened earlier, that we can support more survivors. And that's the reason why in the latest NOFO, each applicant for this particular program had to provide a table where they talked about like what were individual coalition members going to do, and we gave examples of the different sectors that are expected. So again, it's been the expectation that it's a multi-sectoral coalition is one of those things. It's a day one type of expectation that we put forward, that we were expecting to have this all back, and that we had not only members of these different representatives from the different sectors, but that there were also persons lay people from the community that were able to participate on those coalitions. Talking about, again, riding on the horse with the best intentions that you're going to help somebody. Oh, I'm here to save you. It's like, some people are like, well, we don't need saving, and more so than that, we actually maybe have the solutions to those problems. And so then put this on here to say that you need to have every sector on your coalition, just because you need to have the sectors that make sense. The people that are going to be impacted by the work that you're trying to put forward, they should be at the table as a part of that planning, to also be a part of the implementation, also the evaluation. So just wanted to stop and give you kind of a snapshot of what some other state cancer coalitions have kind of looked like. And so we've seen across the board that all 100% of them typically have public health representatives, but they also have people from colleges and hospitals. You have professional associations, you have local businesses, you have local and state officials. I've seen the media representatives of mayors and others that have been a part of these state coalitions. And so one of the foremost things for an NCCCP coalition is, again, that overarching cancer plan, and that these are going to be the things that help to identify or help to address the burden of cancer in a geographic area, and lays it out over the course of like the next 5 years or whatever or however many years you deem. What we have seen is that it's typically those are 5 years, have been every 5 years, but here recently we've seen even longer periods of time for that cancer plan. It just needs to be manageable enough to give you the longer term vision of what you're trying to accomplish, and helping to prioritize the various foci over those 5 years, but also short enough or also nimble enough that you're able to make adjustments according to new trends that may pop up. The other is that we've seen that there are coalitions, and again, there were variations of this in the past, that you had coalitions that had dedicated staff and others that didn't have dedicated staff. You had some that were 100% focused on coalitions, others that maybe had 25% of their time their time devoted. As I mentioned before, we've adjusted that for this particular NOFO, where we are now have recommended and put forth that there are dedicated staff to help support the coalition. And I'm just not meaning just from like logistics type of thing, but again, to be able to bring information, that data that the health department has, to say, hey, this is what we're seeing in terms of trends, or these are some policy system environmental types of strategies that some have suggested may be considered for this particular state. And the other part of it is that the support of the coalition doesn't necessarily always have to be that you have like just the health department. You can also have people from outside of the health department, other nonprofits or foundations that provide staff to support the coalition. Most of the coalitions that we have are volunteer run and supported by CCC staff. And one of the things that we've noticed in terms of successful leadership has been where the leaders of the coalitions, you guys may have co-chairs or others, that they really empower the membership to be able to make decisions, support decisions, like data-informed decisions. So it's not a top-down style where someone's coming in and say, hey, we're going to do X, Y, and Z, versus presenting the data and then coming up with what is that collective vision to help support those efforts. We have the other is that they're also been organized in different kinds of ways. There have been some that haven't necessarily had like a single, those that have had like a single chair person, and then the rest of the organization has been pretty flat. Or like what we see probably the most times is that you have a single leadership group that is more so like a board type of thing, where you have several people that are a part of that leadership group or executive committee, and then having other multiple groups that lead various leadership functions. One of the things that would put forward that I've also seen as being extremely positive has been having term limits for everybody. It's always great every 2 to 3 years, especially if people that are sometimes questioning, will why are we, why are we together? Or, things have happened. The coalition has been in existence for 20 years, and the people that were on originally, have retired or moved on to other types of positions, and the organization is still there, and they're still sending, this person to the meeting, but that person doesn't necessarily have the same level of commitment that the previous, person may have had. So it's always good for a number of things that, for everyone to kind of re-examine the role, having those 2 or 3 year term limits gives at the very least a point in time for everybody to kind of reflect on the relationship. Is this still working? Are there things that need to do if I'm going to kind of re-up? Or like, are there certain things that may need to be adjusted? Like, what should be the expectations, so that you don't have people on the organization, just have people on the organization. We have had some other states, where, people will brag, oh, we have 500 people on the coalition, or we have 200 people on the coalition. Well, the number isn't that important. What it comes down to are the people, and whether or not they have the influence, the influence and the resources to be able to make things happen. I mean, if that means it's just a handful of committed people, and by committed people, I don't mean that people who are just kind of like on fire for the cause, like, oh yeah, we have, this person, I don't know, just so I don't accidentally use a name that's an example of somebody on your coalition. I normally like to use names, but in this case, I'm trying to avoid it, just to make it sure, like, I'm not trying to call out anybody. But let's say, like, yeah, this person, who's very dedicated, they make every meeting, they're always there on time, they come early and stay late, but maybe, they really don't have any influence or the resources to be able to support what the coalition is doing for any one of those areas: prevention, screening, or survivors. That's the reason, it's still okay, for the person to be engaged, but that also needs to be buffeted by people who actually have the resources to be able to make things happen. So for the coalition, and it's really important that, we take steps to be able to sustain coalitions. There was a 2013 training session that NCCCP and others had done several years ago, that identified 5 elements for successful cancer coalition sustainability. And so I actually am going to read these 5 because of how important they are. 1, that is increased marketing of the coalition by simplifying its mission. I mean, you can't be everything to everybody. The cancer plan kind of gives you what that focus is for your coalition. That there is improved networking, including flexibility in coalition meeting location and attendance. That one of the best coalitions I ever see, local coalition I ever saw, was in Boston, Massachusetts, where they actually would move their coalition meeting around the city, so that different members of the coalition, who had difficulty traveling or access, could be there. And I mean, as a matter of fact, one of the housing multi-unit housing units that was there in Boston, they actually held one of the meetings that I had an opportunity to be able to attend, actually in the housing community, so that a couple of their residents, who were like the lay members of that coalition, so that they could participate and so that they could host. There's also increased membership satisfaction through transformational leadership. None of us like going through the motions just to be doing something. I'm very big on everything being done on purpose, and I know that's the reason why that you all are here, that you're trying to do things on purpose, that you're not here just to kind of waste your time. That you also revise the working structure of the committees, so that there's improved accountability as needed. The thing is, that again, we're doing things on purpose, but we also want to make sure then that we are all kind of playing, serving in our role, our appropriate role to bring those things about. And then 5 is that there's enhancement of partner satisfaction with coalition activities designed to recruit and retain new partners. So again, it's not a numbers game. It's about identifying people that are potential partners, doing the research. What is the mission? What is it that they're doing? Is it, if you're trying to work in schools, do you have an education partner at the table, and one that could help to kind of carry that water on your behalf for a policy system environmental improvement that you're trying to do at the school? And when you start seeing people are very purposeful when in being recruited, when other members who are when other people who are already members seeing again that same type of deliberate approach, people tend to be more satisfied because everybody that's at the table, that it's not about the fluff, it's not about just having numbers. It means that everybody that was there is there on purpose. So some for future considerations, would just ask think about, if you haven't done so already, conducting a member assessment and evaluation, and then sharing those outcomes with the membership. And this type of assessment isn't just about kind of like the satisfaction type of thing. Like, are you satisfied? Are you having fun? Are you enjoying this? Do you find this worth your time? But also, the other kind of thing is assessing, like, what are some of the decisions that have been made? What are some of the, what's the direction of the coalition, giving people opportunity to be able to weigh in. Another is reviewing 9 habits of successful comprehensive cancer control coalitions. This is a resource that you can find on the Comprehensive Cancer Control National Partnership website. There's actually a latest edition that talks about all the different habits of successful comprehensive cancer control coalitions. And then the other thing is that in the future, if there are ever any issues that you may need to have worked out within your coalition, sometimes it's good, to have the health department to facilitate. Sometimes people don't like for the health department to facilitate, or another member of the coalition to facilitate. So if that's the case, consider hiring an outside facilitator. So the other thing is that would want to talk about again is, I can't stress enough that partner quality means more than a number of partners. What good is it of having 100 people on the roll for a coalition when you know that only maybe 10 or 15 are really active? And then of the 10 or 15, how many of those are actually influential? And that's the reason why this go around also placing a greater emphasis on leadership. That we know that anyone can be a leader, but leaders set the tone for those organizations, and we know that the organizations set the tone for sectors that then set the tone for communities. That's how we bring things to scale. And so again, with the different types of agendas, those things are fine, that there are differences. It's okay for there to be differences in terms of the people that come to the table, but we know that you're only able to mobilize on commonalities, and the commonality here is cancer. And as we talked about, like in the previous slide, was doing an assessment in terms of having that kind of relationship where you're able to talk about what are your sincere thoughts about the coalition and your relationship with the coalition, that it comes down to the benefit. Because the fact is that if people see the benefit, people will partner. It's not just a matter of saying like, hey, don't you know that cancer is important, and be able to roll off statistics. That in and of itself is not going to be enough. If you're trying to engage a business owner to be able to support that, or say, or like, or someone from the private sector, being able to talk about the impact that it has on the bottom line is going to be the thing that may more likely cause them to partner, versus solely getting them to agree that cancer is an issue, and that and to support a strategy that you're working on. The other is that the other thing is that I'm often asked about is the technical assistance and capacity building for coalition members. When, to be quite truthful to you, since I can't see you, but I feel like we're all fast friends now. We all go back now at the very least 54 minutes that I've been holding you captive. That people don't need technical assistance to be who they are. That if your plan needed a lion, a tiger, and a bear, and you've recruited an elephant, a goat, and a cat, yeah, that elephant, the goat, and the cat will need technical assistance to try to be a lion, a tiger, or a bear. But why not go out, actually use your time and energy, if you're going to be using it, to actually work with those to recruit those people that are already who they are. And the other thing is that relationship drives availability of resources. The other we often see that there are well, I won't say often, sometimes see that, coalitions say like, our coalition doesn't have very many resources. And when you start hearing those types of things, it always questions, well, one, the composition of the coalition, but the other is the strength of the strength of the relationship. Because the fact of the matter is that if a person comes on, regardless of what their reasons were, let's say like, hey, I'm only coming to the table to help support this workplace initiative is because I think it's going to help to help our bottom line. It's going to help to decrease absenteeism. It's going to hopefully reduce my healthcare costs for workers. Even if that may be the case when they get there, if seeing that there's a progress that's being made, seeing that there's a plan in place and that everybody is there is being very deliberate about the plan, that's when people start feeling more comfortable sharing resources. And so sometimes, the thing is that people aren't sharing. It may not be that there is a lack of commitment, but sometimes, people want to see what it is that you're going to do. When I was doing leading partnerships for HIV, for some of our national, for the Division of HIV/AIDS Prevention, I recall working with some high profile people. And then when they started making recommendations of people who could help support our effort, they weren't necessarily the same people as who didn't necessarily enjoy the same type of stature or have the same type of resources as just like one partner. But after they saw that we were treating all these other persons the same, the way I was raised, my father pastored a church in Michigan for 30 years. Mother was also very focused in community. They always taught me that there are no big I's and little U's. Everybody is important, regardless if someone has a lot of money or someone has no money, if someone's educated or someone has no education, that everybody is important. And so by treating everybody with equal importance, we started seeing then that the influential partners, the ones that did have greater resources, started bringing more of their friends to the table that had those greater resources. So I'm finished up here. I just have a couple more slides here. So relationships then are key. And so with that, it's important to assess those relationships. How are things going? How do I feel about the contributions that I'm making? How I'm feeling about how I'm benefiting from being associated with the coalition and having those types of conversations, or sometimes even categorizing it. There's some people in terms of partnerships where, maybe it's that you don't necessarily need to partner with everybody in the state to do well, but certainly, if they're in a certain category, at the very least, to communicate with them, to be able to share the progress that the coalition is making, be able to share the epidemiological profile of what's happening with cancer. And then as you move them across the continuum to being closer collaborators, where they're actually putting in financial resources, other types of in-kind resources, then you can recategorize that kind of relationship. The other is that after you've identified the people, that you've assessed them, you brought them in, is about activating the partnership and activating those relationships around those policy systems and environmental types of strategies, that you monitor how the progress is going with the relationship. You monitor how the progress is going with the actual strategy that you're trying to get in place. And then you take time periodically to reassess and to recategorize. So again, I place a great deal of emphasis on leaders. And the idea is that leaders, and again, this doesn't necessarily have to mean about people who have a lot of money, but it's people that have the ability to be able to exercise influence and are able to make things happen. So the criteria that for your consideration as you think about new members that you may bring on, or as you're assessing the coalition, is whether or not they have relevance. If you're working in schools, does this person have the ability to influence schools? If you're trying to work in federally qualified health centers, do they have the influence there, or in the healthcare system? Or for businesses, do they enjoy that type of representation, or within the faith community? Do they have the ability to be able to influence those resources in individuals? Leaders like hanging with other leaders, and we all know that there are certain voices where you live, that certain voices are louder than others. The other is connectedness. are they able to have that help you with that influence on a jurisdiction-wide landscape? And visibility is that, do they also enjoy the respect of other leaders and community members? So this essentially is what it comes down to, whether or not they are involved in the sector. And so we've provided examples in the past of what coalition members could do for different types of sectors, like who would be the type of member you would need from what sector, and what could be their potential role in doing so. And again, because I've already kind of talked about that over and over and over again, I won't belabor that point, but I will end here and say this, that it still is about keeping the end in mind, and the end is the people, and it's all people within the state of Wyoming. So it's not enough that we were working with just like one corner of the state, or that we're focusing on some more well-populated areas, the rural areas, the frontier, say it's like frontier state. Everybody is important, and it is possible to reach everybody if we do it intentionally through our coalition, with having the right people at the table, with the plan that we've all contributed to, that we're all held accountable to, and that we all help in advancing. And so with that, I thank you all again for your time and attention today, and I wish you well with all your comprehensive cancer control efforts.